Hello, everyone, and welcome to our UCCS's COVID-19 Research Forum. I am your Associate Vice Chancellor for Research, Jessie Smith. And in line with the land acknowledgement of the University of Colorado, please allow me to begin today with an acknowledgement of the land upon which we learn, teach, live, and yes, sit at our computers today. We recognize that this land is the unceded territory of the Ute peoples. It is our obligation to not only pay our respects to the Indigenous communities, past and present, who call this land their own, we must also commit to unraveling the harm experienced by elders and empower the present generation. And this includes considering the disproportionate harm of COVID-19 to our tribal communities. Indeed, COVID-19's impacts are felt far and wide as the pandemic and the necessary mitigation efforts have upended our lives. Amidst the stress and uncertainty, many of our scholars have pivoted to turn their expert eye on studying the pandemic to build new knowledge, discover new ideas, and create interventions and strategies to improve the state of our planet and the human condition. What you will learn today is just a small sampling of the excellent research and creative work unfolding here at UCCS. So, without further ado, let me turn it over to our moderator for today, Provost and Executive Vice Chancellor of Academic Affairs, Dr. Tom Christensen. Tom?
Thank you, Jessie. Before I introduce our panelists for today, I'd like to say how delighted we are that CU Regents Sharkey and Spiegel are able to join us for this session. I also want to thank each and every one of you for tuning in to what I'm sure will be an inspiring and informative event. Today, 4 faculty from across campus will share their research on a variety of topics related to the unique challenges that we have seen from this public health crisis. Dr. Judy Scott, originally scheduled to present today, had a family emergency and will not be able to join us. COVID-19 has impacted our lives in ways that we are still learning and will continue to be researching for years to come. Each of our presenters today has prepared a brief presentation on their work, and after everyone has had a chance to present, we will open it up for some question and answer period. As time allows only for a short overview of the research, I encourage you to submit your questions through the form link that can be found in the description of this video. Hearing your questions and comments is an important part of the research process. Now, let me introduce our first researcher. Dr. Christy Samuelson is an associate professor in the Department of Psychology and associate director of clinical training. She also serves as the director of clinical research for the National Institute for Human Resilience. Dr. Samuelson is a clinical psychologist who joined UCCS in 2015. Her research has specialized in the field of trauma psychology since 2001. With much of her work surrounding neuropsychological functioning in post-traumatic stress disorder. Her talk today is focused on mental health and resilience during the coronavirus pandemic. Welcome, Dr. Samuelson.
Thank you, Dr. Christensen, and both Dr. Christensen and Dr. Smith for holding this forum and inviting me. I'm going to be talking about my research involving mental health outcomes due to the COVID-19 pandemic. So this is what I'll be presenting today as part of an ongoing longitudinal research project conducted in my research lab. So first, I'd like to acknowledge my wonderful team of graduate students and research assistants listed here on this first slide. And then you can go ahead and advance. Thanks. So the onset of COVID-19 to the world and here in the United States brought stunning changes to all of our lives. We were directed to remain in our homes, to isolate. There was massive fear, anxiety around what COVID was and what it was going to bring to us. And so as trauma and resilience researchers, all of my lab, including all of my in-person studies, shut down. Within my lab, we immediately started noticing our own reactions to COVID-19 and immediately started developing our own research questions. Our reactions varied from intense anxiety to maybe mild annoyance. So we wanted to develop a research study to understand the effects of COVID-19 on mental health. And then specifically as trauma researchers, we wanted to understand COVID-19 as a potential trauma. So in the world of psychology and psychiatry, post-traumatic stress disorder typically refers to symptoms endured from a past trauma that involves a threat to life or a threat of serious injury. But COVID-19 here is its current, ongoing. So how can we understand COVID from a traumatic stress framework? That was one of our overarching aims of the study. So we quickly developed an online study as we were aware of the effects of COVID-19 beyond just the threats of getting COVID, fears of dying from COVID, losing a loved one to COVID. It also included major economic pressures, forced social isolation, and this ongoing sense of uncertainty or dread that we wanted to capture. COVID research started almost immediately. In the first months following the onset of COVID, there was a plethora of research coming out, a limited research on the mental health. But it was showing us that there were these intense health disparities in both getting COVID and dying from COVID, in which racial and ethnic minorities and persons of lower socioeconomic status were struggling at disproportionate rates. Trauma adaptation theories emphasize this interplay between these kinds of socio-contextual factors like race, ethnicity, age, socioeconomic status, and how they interplay with person-centered factors. So in designing the study, we wanted to capture both. So looking specifically at internal psychological resources, where we were focusing on coping variables, specifically appraisals about the self and the self's ability to manage stress, and then how they interplay with demographic and health disparities variables, the degree of risk of getting COVID and dying from COVID. So that would include variables like being forced to work outside the home, medical risk conditions, and then other negative COVID impacts like losing a loved one or financial impacts. So that chart there shows you all of the array of types of variables that we wanted to look at concurrently in the same model. We wanted then to look at rates of depression, anxiety, and PTSD while examining these predictors concurrently. So I'm fortunate to have a fantastic statistician on my team who could employ machine learning models. These are complex, robust statistical models that allow for more or less a rank ordering of the most important predictors while considering a large number of predictors concurrently. Okay, so go ahead to the next slide. Okay. So of course I have a lot of data for you. This is an ongoing longitudinal study, but this is the baseline cross-sectional data. So we recruited 527 participants online, included from 44 states, 23 countries. This data was all collected back in May. We immediately tried to get this study off the ground to capture that really stressful early part of COVID-19. And we've been collecting data longitudinally, assessing these folks every month so we can look at longitudinal trajectories of adaptation. So let me start with the chart on the left. This shows the rates of diagnostic levels of depression, anxiety, and PTSD. So we're not just talking about symptoms of these disorders. These are the actual rates that respondents showed of exceeding the cutoff on measures suggestive of likely diagnosis of those psychiatric disorders. So you can see they're extremely high. 44% of a general population sample is experiencing depression. I can't quite see the red one, but I think something like 29% for anxiety and 19% for PTSD, which is especially interesting because, as I noted before, post-traumatic stress disorder should be about a post-trauma, and yet people are talking about intrusive thoughts and hypervigilance to a current ongoing stressor. Okay, so the middle graph there, this shows how we grouped distress with latent profile analysis. So basically the take-home message of that graph is that over half of the participants in the sample were experiencing moderate to high levels of distress across multiple psychiatric disorders, so more than half. And then finally, the last chart is the results of the machine learning model. So the model allows us to rank order the importance of variables, and this one is in predicting the low distress group. So that's healthy adaptation. Not all of the variables I talked about on the prior slide are included there. These are the variables that were the most important and significant predictors. The main theme here is that the psychological resource variables are by far the most important predictors. And coping self-efficacy is far and away the most significant predictor of healthy adaptation. So let me briefly talk about what that means. This is specifically coping self-efficacy to the pandemic. So that refers to a person's belief that they can cope with the demands of COVID effectively. And with all of these variables together, by far the largest predictor. You can see some other important predictors are related to coping and how we think in terms of coping with a trauma. So generally in the world of trauma, we want folks to use coping styles flexibly. So to use both forward-focused coping and trauma-focused coping. Forward-focused coping is, hey, distract yourself, don't get too caught up in it. Versus trauma-focused coping is sometimes you need to address the trauma, you need to not avoid it, you need to work through it. This is one of the most interesting findings here, I think, because we're showing that forward-focused coping is helpful and trauma-focused coping is not. So when an ongoing stressor like COVID-19, you want to avoid, distract, think about the future, get through it, and not spend a lot of time trying to process what is COVID and how you're dealing with it. The next major theme here is that variables related to health disparities, demographics, the COVID demands and impacts, you can see from that chart that they play a really small role in mental health outcomes. It was really all about those psychological resource variables. So the take-home message of these findings for me is that we can intervene to help individuals develop better coping skills and better coping self-efficacy. From a public health perspective, that's great news. We obviously can't intervene on variables like gender and age. So as a discipline, trauma and resilience researchers can then focus on both preventative programs and interventions aimed at building these important coping skills, which is a major initiative of the National Institute for Human Resilience here at UCCS. Thank you.
Thank you, Dr. Samuelson. Just a reminder to our audience, if you have questions, please submit them at any time through the form that's provided there on the caption for the program. Our next researcher is Dr. Tara Sipan-Robbins, who is an assistant professor in the anthropology department and a Becher investigator. She's a biological anthropologist who's been at UCCS since 2015. Her research includes collaborations with the Shuar Health and Life History Project, the World Health Organization's SAGE Project, and the UCCS Gerontology Research Affiliates. Her talk today will be on Old Friends Meet a New Foe, a potential role for immune priming parasites in mitigating COVID-19 morbidity and mortality. Welcome, Dr. Robbins.
Hi, everyone. And thank you, Dr. Christensen, Dr. Smith, for inviting me to speak here today. Thanks, everyone, for tuning in. My research centers on possible roles that parasites, especially intestinal parasitic worms, might have on presenting the worst outcomes associated with COVID-19. A large portion of this talk comes from a paper my colleague and I published in the journal Evolution, Medicine, and Public Health this past fall. So that's the information on this slide, if you're interested. So I'm interested in understanding the negative and positive health effects that stem from the very long history that humans share with our pathogens, and especially our parasites. Throughout human evolutionary history, we would have regularly been exposed to a number of different pathogens, and this includes viruses, bacteria, and especially much larger parasitic worms. In fact, there is an entire branch of our immune system that exists specifically to respond to these larger parasites. Thus, pathogens that have a long history with humans have come to be called old friends because they've shaped us in many ways. The hypersanitary conditions that many humans currently find ourselves living in is a relatively new phenomenon, and most of us can say that we've never been exposed to parasites. So, oh, sorry, can we go to the next slide, please? I forgot I'm not in control. I actually clicked and it didn't go. So, this hypothesis, this old friends hypothesis here, asks the question, what happens to our immune systems now that we aren't getting exposed to the parasites and the other pathogens that we've come to rely on to shape our immune responses? And you can see that kind of outlined here. You can also see a lovely photo of 3 different types of parasitic worms. So evidence suggests that without parasites, we're actually more likely to develop diseases that are associated with immune system dysregulation and elevated inflammation. So things like allergies and autoimmunity and even heart disease have been linked to a possible loss of this kind of immune dampening response. I investigate relationships between parasite exposure and immune system regulation and development in Amazonian Ecuador and in the rural southeastern United States. And I focus on soil transmitted helminths, which are parasitic worms, and they're interesting to this kind of research because they have relatively innocuous effects on human hosts, but they also have this ability to hijack our immune system, to reduce inflammation, and to encourage chronic infections with them. So for the rest of this talk, I'll just refer to them simply as helminths. Next slide, please. So when we first started hearing about the novel coronavirus, SARS-CoV-2, and the associated disease, COVID-19, all signs pointed to the worst health outcomes and the worst effects being associated with overactive immune responses and with unregulated inflammation and with uncontrolled immune cell release, which is called the cytokine storm. And I immediately started to wonder, how does infection with parasitic worms in helminth endemic areas, how does this affect the viral spread and the health outcomes associated with the new virus? So when I say endemic areas, I'm referring to places where helminth infections are common. These tend to be more tropical areas. They tend to be locations with limited access to healthcare and sanitation infrastructure. And this image here highlights many of the ways that soil-transmitted helminths should theoretically improve COVID-19 outcomes. Specifically, helminths trigger a branch of the immune system that turns down inflammation or turns down other immune responses. And by doing so, they release anti-inflammatory and regulatory immune cells. This turns down inflammation and other immune responses, and for this reason, co-infection with helminths should result in less inflammation and make cytokine storms, which is one of the leading causes of tissue damage, less likely. And overall, this should reduce the likelihood of, or reduce the severity of COVID-19. Further, there's evidence to suggest that the branch of the immune system that helminths trigger is associated with a reduction in ACE2 receptors on human cells. These are the receptors that SARS-CoV-2 uses to enter human cells. So by reducing the number of these, we should also see a reduction in viral load and the amount of virus that infects a person. On top of that, infection with helminths is also related to reduced incidence of inflammatory comorbidities, things like cardiovascular disease, obesity, autoimmune disease, and inflammatory asthma. And these are all comorbidities that have been shown to cause worse COVID-19 outcomes. So by preventing these, helminths may further reduce COVID-19 severity. Next slide, please. So the pandemic has halted travel, making understanding the effects of helminths on COVID-19 in endemic areas difficult. And these are already difficult to access regions. Endemic areas tend to be places where they're largely neglected. There's very little medical attention. So while I've not been able to go and test these hypotheses directly, I can look at the effects that helminth infections have on cytokine profiles from a pre-pandemic sample. And as I mentioned, one of my research projects is conducted in Amazonia and Ecuador among the indigenous Shuar there. So looking at data from stool, and you can see an image of that in this photo of a couple different studies looking at these cytokine levels. But looking at data from stool and blood samples collected between 2011 and 2016, we see evidence that helminths decrease both localized intestinal inflammation and overall systemic inflammation. Interestingly, we also see that they alter relationships between inflammatory cytokines that are associated with the cytokine storm. So while this isn't, and that I could go on about that forever, but while this is not direct evidence, it does show that parasites have promising effects on regulating inflammatory processes in these helminth endemic areas. And this means that theoretically they could be reducing the worst effects of COVID-19. Next slide, please. So there's also an anecdotal evidence that helminth endemic areas have not had as bad of COVID-19 outcomes. For instance, studies that compared COVID-19 lethality between countries and regions suggest that there are higher death rates in wealthy regions compared to poorer areas with less access to medical services. The latter, though, are the kinds of places where we tend to see helminth infections. However, this is complicated by a number of factors that you can see in this slide here, because all of these factors affect COVID-19 severity and spread. This includes things like population density and access to healthcare and sanitation levels and hygiene education and rates of malnutrition. And all of these are going to have numerous nuanced effects on both helminth infections, COVID-19, and other health outcomes. And it's also possible that due to these circumstances, infection and death rates in these populations are not being as closely tracked. So that can also skew that anecdotal evidence. So more direct research beyond regional comparisons is needed, and hopefully we'll be able to get out there, get vaccinated, and do this kind of research soon. It's important to note before I finish this that this research is not encouraging people to infect themselves with parasitic worms or with helminths because they have many negative side effects and could make COVID-19 worse. And we can talk about that more in the Q&A if you want to, but under some circumstances could actually make it worse. But it's important, the important point here is that people living in helminth endemic areas often lack access to medical care and sanitation infrastructure. And that is needed to prevent infections with multiple types of pathogens, including COVID-19 and soil-transmitted helminths. So this makes understanding how helminth infections are affecting health outcomes with COVID-19 extremely important. Thank you.
Thank you, Dr. Robbins. Moving on to our next researcher. I'm pleased to introduce Dr. Marianne Cutter, who's a professor in the Department of Philosophy. She's been with UCCS since 1989 and is the winner of the 2020 CU Gee Memorial Lectureship Award and is a CU President's Teaching Scholar. She's also the author of numerous publications on the philosophy of disease and bioethical topics. Her talk today addresses the uncertainty of death, the case of COVID-19. Welcome, Dr. Cutter.
Thank you, Tom. Can everyone hear? Thank you to Associate Vice Chancellor for Research, Jesse Smith, and to our provost, Tom Christensen, for supporting this kind of work. I'm very honored to be part of this group. I also thank you so much, Dr. Samuelson and Dr. Robbins, for your work. I'm so inspired by it. My work is from the philosophical standpoint, so it's going to sound, I think, quite different. But I think it's also very important. I'm a philosopher of medicine, as Provost Tom Christensen indicated, and I work on biomedical ethical topics. I've been spending close to 30 years teaching death and dying here on our campus, and that I think you'll see the influence of that work in the current project. Before we move to the next slide, the photo that is first up is the photo of a Nepalese soldier who is charged with burying the dead. This was taken in November 2020. I, like Dr. Robbins, do work around the world, and I've not been able to travel, so I've been relying on some photos that others have sent me. So what's interesting about the photo is I think I'm calling it in my own work is a new face of death. This person is double masked, and it has, we're in Colorado, so it looks like a ski goggle of some kind. But if you notice the tag, it says remove before using or something like that. It's sort of scratched off. So the film is not even removed. And the person who sent it to me indicates that there's moisture on the lens. So I've just, I look forward to next year doing much work overseas, hopefully to look at, again, these new faces of death. Next slide, please. So some of us think a lot about death and how one or others might die these days. And certainly, Dr. Samuelson, you're reminding me of yes, how much some of us are thinking about death these days. And I think from a philosophical standpoint, there's a number of reasons. The first one is just some numbers. Death from COVID-19. This is data that I pulled from 2/6/21, so we're up a number of. In Colorado, we've experienced 5,804 deaths. In El Paso County, 715. I think we're up to 718 as of yesterday. In New York, 44,012 deaths. In the U.S., 405,000. And in the world, 2.31. Now, I'm reminded of something Dr. Robinson says is, it depends on how we count the numbers. So at this point, this is the data that's disclosed, but I wonder sometimes as a philosopher of medicine, to what extent are we picking up, there's number of individuals who have died with comorbidities. So in what category might those individuals be? But putting that aside, these are significant numbers. We're used to, in the United States, about 500,000 dying from heart disease, something that I've spent a number of years of my life working on breast cancer. We're used to about 42,000 women dying of breast cancer each year. So these numbers are, they're significant in terms of a population of individuals who are dying. A couple of other pieces of data is that 40%, I think it's 40% of those dying are in 1% of a certain population, and that is those in nursing homes. Those over 85 have a 600 and whatever percentage chance of dying from COVID. So, there's some really interesting ways to, again, pulling from the statisticians here among the group is interesting ways to look at these numbers. The bottom line is that they're significant. They're significant deaths. My own work picks up on the second piece a little bit more. Is that I've been wondering the extent to which we're thinking about death and dying more because of the uncertainty of dying from COVID. Now, as a number of us were sort of sequestered a year ago, March, right? And we went back into our homes, we went back into our communities, and the conversations, we all heard similar conversations. Uncertainties about transmission. Is it by aerosol or is it by surface, right? All that stuff. The uncertainty of the diagnosis. Is it the swab? Is it the sputum? Is it where does the antibody test fall in? Prognosis. We all know stories of folks who have had a much worse case experience with COVID than others. Treatments. We all know the debates about remdesivir and hydrochloroquine, and all the treatments aren't the same. Right? And we are experiencing the discussions about the uncertainty of vaccines, right? And there's many vaccines out there. The United States is, for the most part, using the Moderna and the Pfizer. The Johnson & Johnson may come on board. The AstraZeneca may come. They're not the same, and they act differently. They function differently in the body. They're made from different things. So there's a whole lot of, picking up on what something Dr. Samuelson said, there's a whole lot of uncertainty with regard to knowledge. And we'll come back to that in a minute. I think a third reason why we're thinking a lot about death these days is some of the, what I would suggest, odd practices, death and dying practices that we've developed in the last year. And I'm thinking in particular of dying alone, I'm thinking of refrigerator trucks, and I'm thinking of mass graves. So on the left-hand side, the photo is of Antonio Navarro in Fullerton, California. And this is a photo from July 2020. And if you notice, or if you see, he's using a cell phone on his, would be the left ear, and he's saying goodbye to his son, Jose. And there's oodles of photos of individuals who are, dying alone in hospitals. Now, I fully realize that there's healthcare providers there, and the healthcare providers are the new heroes and all that kind of stuff. But there's practices with regard to death and dying in the clinical setting that are different, where loved family and friends are not allowed in. And so when I talk about dying alone, I don't mean that the healthcare providers have deserted. No, they're definitely the heroes. It's just there's a new way of dying that we haven't, maybe picking up on my own interpretation of what Dr. Samuelson says, we haven't done some forward thinking about that. The middle photo is the photo, very riveting photo of the refrigerator trucks outside Bellevue Hospital in New York. This was about June 2020. I could have chosen a picture from Los Angeles or San Antonio, Texas. I mean, the refrigerator lot. What's notable to me is notice how they're not marked. They're plain trucks. And they're typically housing the bodies of those who did not have loved ones come to the hospital. The hospital needed more room, so the bodies were put in there. And then there's a whole bunch of other kinds of stories, and that I'm unpacking that is, the refrigerator trucks. On the right-hand side is a photo of mass graves that out of Brazil when they hit the epidemic or a height of their epidemic in July of 2020. I could have also used a photo of the mass graves in Hart Island, which the Department of Corrections developed to put the bodies of those who were dying in correction facilities from COVID-19 into the grave. And what, before we go to the next slide, what I pause at is that I think these are some new ways new death and dying practices that we have before us, not just psychologically, but visually. Next slide, please. I think COVID-19 gives us an opportunity to think about death and dying. And my work has been that. It's been 30 years of teaching death and dying, looking at end-of-life issues, contextualizing end-of-life issues within the larger framework of spiritual and secular views with regard to death and dying. I just want to share, because I find this also a key point that I don't have time to develop. There's no spiritual or secular tradition. Again, there's no spiritual globally or secular tradition that supports our allowing people to die alone. Now, people can choose to die alone, but there's no spiritual or secular tradition. There's a robust similarity among the traditions. So in kind of moving through some further reflections before I wrap it up, is I think COVID-19 is an opportunity to think about a few things. And I think the first thing is death and how we might die. And I often think I'm in the kind of work that I'd rather not be in, but the reality is that we'll all die. And I find it philosophically so interesting that it's so challenging to have discussions about death and dying. So what I would really encourage, I mean, I would first go to the educational system. I think the educational system can do a much better job in talking about death and dying. I'm part of that in my limited way. We can have conversations about death and dying, and there's a lot of conversations that are going on now, or part conversations, right, Dr. Samuelson? A stressful conversation, depending on how they're going on. I would encourage, if you're interested in reading more on any of this, is to look at the material from the Conversation Project, from the 5 Wishes group. I think there's a second opportunity here, and the opportunity is to think about clinical uncertainty or the limits of medicine. And I think, and this is, I think, the unique part or the particular part of what I do in terms of the research is how to think about how we might manage clinical uncertainty in light of not simply COVID-19, but in light of 21st century clinical possibilities and limitations. Now, my message is the same whether if I'm doing, working in cancer medicine or working in genetic medicine. The 21st century medicine promises a lot, but is still limited. It promises a whole lot, and it's amazing, but it is still limited because it's still an empirical body of knowledge that has inherently limitations. So it can't solve all of our problems. It can't deliver perfection. And if I might suggest, and then I'll end up with an ethics point, that I think some of the practices, the earlier slide, the practices that we see, locking hospital, healthcare facilities, nursing homes down, and not allowing loved ones' families who are willing to go in, and mass graves and the refrigerator trucks and taking bodies and putting them in empty rooms and shutting the door or putting them down in the basement. There's all kinds of stories. Is a function of our not addressing the reality of a pandemic, one, and number 2, life in general. Okay, so one of the things, again, I'm working on is how can we better manage clinical uncertainty? And I think the messages are clear in cancer care and genetic medicine, but most of us walk around thinking we're not going to get cancer and I don't have a genetic disorder. But most of us feel exposed to COVID in some way, I think. The last point is the ethics of some of the current clinical practices. I think some of the current practices raise a whole bunch of ethical issues regarding what great Beecham and Childress have developed regarding patient rights, patient dignity, patient's best interest, and access to healthcare. And we've heard a little bit about access to healthcare today, and there's so much work to be done on that. And I think COVID has, if you will, shined light on problems we have with access to healthcare. If I'm a Native American or an African American, I have almost a three times chance of dying from COVID. If I'm over 85, I suggested that later, I'm 600 times more likely to die of COVID. And we can run those kind of numbers, and there's like, wow, we see ourselves much. We can't hide, we can't hide from this one. In terms of respect for person, the first point on the last point, and this would be the next slide, sorry, is it, or the prior slide, just for that point. The slide before that, yeah, no, the slide after that, sorry. That's great, thank you. In terms of the respect for person, I don't think anyone signs up for this. So patients are not saying, please let me die alone. In fact, they're asking, please let someone come to my bedside, please. And in terms of their best interests, and this is work that's being done in current psychology and with regard to mental health, there's great data emerging showing that locking individuals down is not healthy for them. There's great mental health toll. So in short, I think a philosophical, if you will, some philosophical reflections on death and dying and what we're doing might, using Dr. Samuelson's comment language, is that might help us with some forward thinking about what we're doing and why we're doing it, and maybe we could come up with some different models. So thank you so much.
Thank you, Dr. Cutter. I'm now delighted to introduce Dr. Gia Barboza, who is an assistant professor of criminal justice. Dr. Barboza was a postdoctoral fellow at the Institute of Quantitative Social Science at Harvard before joining the faculty in the School of Public Affairs at UCCS in 2019. She was recently named to the editorial board for the journal Child Maltreatment. Today, she's presenting work as part of an interdisciplinary team at UCCS that includes Philip Brown, Assistant Professor of Computer Science, and Lisa Hines, Associate Professor of Biology. The focus of their work is on rethinking community approaches to identifying and preventing family violence during a public health crisis. Dr. Barboza.
Good afternoon, everyone, and thank you so much. And first, I'd like to take this opportunity to thank everybody who made this research possible, including Provost Christensen, Dean Reed of the School of Public Affairs, Associate Vice Chancellor Jesse Smith, and of course, my colleagues, Drs. Philip Brown and Lisa Hines, PI and co-PI, along with me on this project. One of the many aims of our research is to create mathematical models that describe the varying impacts of public health measures, such as social distancing, on the increased risk of potentially life-threatening situations for vulnerable populations, including, of course, COVID's direct effect on health, but also its indirect effect on health, for example, violence and abuse in families. The COVID-19 pandemic has resulted in public health measures such as safer at home orders requiring business closures and residents to stay at home while not participating in essential quote unquote activities. The result, as everybody knows, has been massive rates of unemployment and social distancing protocols. The first question that we were concerned with is, what do we know from existing research that may be helpful for families facing potentially abusive situations? First, based on pre-existing social disparities, we know that individuals and communities have been differentially impacted by COVID-19. In particular, COVID-19 has exacerbated pre-existing vulnerabilities, creating a context context that is more conducive to domestic violence, as vulnerable men, women, and children are trapped inside of their homes with their abusers. Second, decades of research has shown that violence clusters in communities characterized by high levels of social isolation, housing and food insecurity, unemployment and loss of income, lack of child care, and mental health issues, which are all factors that have been exacerbated by this pandemic. Third, when individuals are sheltered at home, domestic violence is not visible. This is particularly true with child maltreatment, which of course is mostly detected in schools that are now closed. So it is critical that we have new methods of detecting domestic violence because the methods that we have in existence have failed us. Therefore, in order to develop preventive interventions, there is an urgent need to create new methods of identifying individuals and communities that are susceptible to family violence and that have been disproportionately impacted as well by the effects of COVID-19 to provide them, with having the resources necessary to be able to protect themselves in their homes. Today, I'm going to briefly share some of the research findings that we have in this regard and share with you as well some of the tools that we've implemented to detect factors associated with increasing spatiotemporal, that is space-time trends of domestic violence during the pandemic, focusing on the context of the city of Los Angeles, California, which of course is my hometown. Next slide, please. Now, this project spans a lot of different facets, as I was mentioning in the beginning. But part of this project aims to incorporate, and part of the project overall aims to incorporate big open data sets using novel tools, data science, and other statistical techniques to better prevent and intervene in domestic violence in families in real time. That provides the justification for some of the data we used, and of course, we hope to expand some of this research in the future. For this particular project, we spatially merged multiple data sources with domestic violence incidents from the city of Los Angeles, which was derived from the open data portal during the COVID-19 pandemic, and of course, pre-pandemic as well data from the California Strong Start Index, which measures family, health, and financial resources, as well as service utilization, and data on school absenteeism, unemployment, labor force participation, poverty, and housing affordability. And of course, we included these measures because, again, these are the very measures that have been pre-existing vulnerabilities and have been exacerbated in the wake of COVID-19. To examine temporal trends of domestic violence during COVID, we used several indices, including social distancing metrics from Google Mobility, Apple, and something called SafeGraph, which has made available many gigabytes of data and have created a social distancing index, which can be merged with the domestic violence data to kind of track people's mobility and see associations with domestic violence. Using this data, along with dates of domestic violence incidents, we created indicators representing key time periods corresponding to things like school closures, the release of stimulus funds, and of course, business reopenings, only to name a few. This made it possible to explore daily trends in mobility patterns, dates associated with different COVID policy implementations, and domestic violence counts. Next slide, please. In addition to the mobility patterns, SafeGraph provides a social distancing index for every census block in the United States. The social distancing index was clipped to the City of Los Angeles boundary file and merged with the domestic violence counts and other spatial indicators at the level of the census block. The figures on this slide show the spatial characteristics of domestic violence, and I'll start with this first. The figure on the right, which is kind of a data science way to present information because it incorporates a lot of things at once, is called a tree map, and it shows the domestic violence incidents by neighborhood during the time of COVID. And I will use it just to highlight 3 findings. During the period of COVID, the most common form of intimate partner violence was simple assault, which in California is defined as physically attacking a victim without a weapon and with no resulting injury. Child abuse and neglect is something that was much less frequently reported. The second is there was substantial spatial heterogeneity in domestic violence risk that exists across the city of Los Angeles. This reinforces the importance of looking at these phenomena in a spatial context. The third is intimate partner and child victimizations co-occur, and hence we can quantify the likelihood of experiencing one form of abuse conditional on experiencing another. Figure 2 shows the risk surface map that we created across the city using something called the Search Similarity Tool in ArcGIS. The tool was used to rank all of the census tracts in the city according to their level of co-occurring risk on the measures that I discussed previously, which again are severe rental burden, school absenteeism and poverty, labor force participation rates, and the Strong Start Index, which is a measure of child resources when they are born. In Figure 2, the highest risk census tracts are shaded darker and are clearly clustered in some parts and areas of the city. Figure 3 on the right of that shows the results of what's called the emerging hotspot analysis, also a tool that is available in ArcGIS. And these results are the emerging hotspot analysis of domestic violence cases across the city. Now, it's important to tell you what the parameters of this model are, because the parameters are what allowed us to kind of identify the risk during COVID. The parameters of the model were specified to aggregate domestic violence incidents into areas representing about 5 city blocks over 1 month time slices, with the most recent time slice associated with the period spanning the pandemic directly. So that's how we were able to do this. Now, as you see from the figure, the results show the spatiotemporal trends associated with domestic violence during the pandemic, including 1, areas where domestic violence has intensified in certain areas in the city, and 2, areas of new hot and cold spots that are shown in red and blue respectively. So these are cases that have emerged as new hotspots, cold hotspots, or intensifying hotspots across the city. Now, of course, there's other types of hotspots and cold spots, for example, consecutive, right? And so we're more interested in how we can identify these new or emergent or increasing hotspots. You'll note as well, and this is an important point, that there is a very strong relationship between the figures 2 and 3. That is, between the areas where there are higher co-occurring risks in certain parts of the city and in areas of intensifying hotspots of domestic violence across the city. Just to reinforce the importance of these findings, if we simply look at the time trend across the city, at best, we see a very, very slight increase in domestic violence, but for the most part, we see no pattern at all. Therefore, by modeling the spatiotemporal characteristics of domestic violence, we're able to identify the parts of the city characterized by differential time trends and then situate those time trends into their spatial context. Next slide, please. Thank you. This slide shows a few of the different modeling techniques we use to predict the likelihood of domestic violence within areas that were shown to be hotspots. Figure 1, and Figure 1 is just kind of a visual implementation of Table 1, and I should have made more explicit what those acronyms mean, so I'll just kind of describe the findings to you. Figure 1 shows the predicted counts of domestic violence decrease with higher levels on the California Strong Start Index and with more labor force participation, and increases with increasing levels of chronic absence, chronic school absence, and measures of severe rental burden, which is you pay more than 30% of your rent, your income in rent. So that's what that measure is. Figure 2 is a map of COVID-19 as quantified by the rate per 100,000 persons in the population in yellow. This is an area of lower COVID risk within the area of higher domestic violence risk. The number of COVID-19 cases per 100,000 that's in yellow is shown alongside the social distancing index that's available from SafeGraph at the block group level, and superimposed on that in the kind of weird polygon shapes are areas or a heat map of the higher counts or the stronger, higher density areas of domestic violence in the city. Now, the reason that I wanted to show this is because it illustrates an important point. The map shows areas associated with high densities of domestic violence and more people sheltering in place. The sheltering in place is given in the blue, even though, as I suggested, the rate of COVID in this area was relatively lower than the city overall. Figure 3 shows the time trends of domestic violence, arrests, incidents and arrests, and the percent of persons sheltered in place from January to November 2020. And that's again using the SafeGraph data that makes available this data over time. So this data can be merged temporally with counts by day to suggest trends. And if you look very carefully, there's really no noticeable pattern that's detected across the whole city, merely reinforcing the importance of looking at these data spatially and spatiotemporally. But you can see that the spike there corresponds directly to the shelter-in-place protocols that were put in place back in end of February, March or so. So a couple of points here. Our findings reinforce the utility of developing intervention strategies that minimize harm to families by targeting resources to specific challenges they're facing within areas of the city. I just wanted to end by noting a few policy implications of this work and then suggesting some areas that we will continue to do this work in. First is most obvious, and something that everybody knows, is that communities have been disproportionately impacted by COVID-19, as well as, however, the measures, the public health measures that have been designed to prevent it. The second policy implication, and the one that's probably the most important to me as I sit on the Colorado Lawyers Committee Housing Subcommittee, and we see increasing rates of evictions during COVID-19. We obviously need eviction moratoriums, and these moratoriums should be extended, not only to prevent housing insecurity as kind of a moral issue in a pandemic, but also as a violence prevention strategy. The third is in schools, policies that eliminate the requirement to record student absences may make it more difficult to assess students who are at higher risk, because absence is both directly related to child welfare and it's also indirectly, and this is what the research says, indirectly related through things like grades. Lower scores on the Strong Start Index, which has been such a robust predictor of every single model that I've run, are associated with higher levels of child welfare involvement and deaths to children under the age of 5 years old, and clearly provide a good indicator of the families that are at risk, given that we are unable to detect some of this risk because, for example, children aren't in school, etc. We hope to extend these results using other data sources, such as data from child welfare. I'm working on that, as well as additional measures. So I hope to extend some of these tools to cases of fatal drug overdoses across areas, and also, of course, across other regions, including the state of Colorado. So thank you, everybody, for listening, and it is truly an honor to be part of this panel, and look forward to any questions.
Thank you very much, Dr. Barboza. Just another reminder as we're leaving our presentation part here, that if you do have questions, feel free to submit those We've gotten a number that have come in. So some of them overlap one another, so that, if you don't hear yours exactly, it may be that we're paraphrasing it somewhat. We will make sure that the presenters do get copies of all the questions and comments, because that is an important part of research, is getting feedback from the community on their work. So everybody will get those. We've got about 15 minutes here before we'll close at 3:15. So I will go ahead and ask a few questions here. Let's go back and start with Dr. Samuelson. Apart from applying your research findings to helping people now during this pandemic, what elements of your findings might we be able to apply to other non-pandemic situations that people might encounter?
Yes, that's a great question. Because obviously we need to think past COVID. We could think to other pandemics, because we could be assured that there will be other pandemics. But even beyond that, I think the best way to apply these findings is to think about other chronic, ongoing stressors that involve uncertainty, right? And so a couple things come to mind, and the main one is people who are dealing with chronic illness or terminal illness. That is a subset of the trauma research world that we know a lot less about, in part because of that ongoing, continuous nature of that trauma. And so I think these findings are particularly relevant for working with that population. How can we help people deal with those kinds of chronic stressors that don't necessarily have an endpoint? And a major factor that's arising here is, how do we shore up someone's coping self-efficacy or ability to deal with the demands of something with that degree of uncertainty?
Great, thank you very much. Let's see, we also have a question for Dr. Robbins. You mentioned at the end that you are not recommending using helminths as a treatment for COVID-19 because they could have other negative effects, including making the COVID-19 worse. Could you elaborate a little bit on that?
Yes, thank you. So helminths are often asymptomatic, except in very intense infections, but they can cause serious problems even in not intense infections. And they can cause things like slowed growth and slowed development in children. They can cause nutrient deficiencies like iron deficiency anemia by causing bleeding, as well as overall nutritional stress by absorbing energy. And some of the larger ones, like giant roundworm, Ascaris lumbricoides, that can cause intestinal obstruction and even death. So they're a very real health problem. And on top of that, their immunosuppressive nature that I just discussed can be problematic as well. Because they turn down our immune responses to favor chronic infections with them, they essentially leave the host vulnerable to contracting new diseases like a virus, say. And they also make vaccinations less effective because infected individuals don't end up mounting, or not infected, but when you're vaccinating somebody and you have helminth infections, they'll make it so that the individual does not mount as strong of an immune response. And that's something that they've seen with a number of vaccinations across the board. So I would add that with the vaccination rollout happening now, it would be important to treat helminth infections before vaccination to encourage effectiveness. But the point here is that even if they make infection more likely, they may prevent the worst effects of COVID-19 that are associated with the overactive immune response. So it's a complex situation with many little creatures interacting at once. Thank you.
Thank you. It's trying to picture all those little creatures, and the complexity of this stuff is I mean, this has been, one of the things that's been fascinating about today is just the different approaches and the different aspects of COVID-19 that we're covering. So just amazing. So let's go on. Dr. Cutter, this work seems very much in line with work that you have done over your career, but what is it that kind of brought you originally to work on this topic?
Oh, thank you. Thank you, Dr. Christensen. Yes, I've been working on death and dying for 30 years, and most of it's been with regard to advanced directives, making decisions at the end of life. So there I work like Dr. Barboza with regard to some of the legal issues. And then I moved into cancer care and making decisions at the end of life. I think what's different is that, again, COVID-19 leads us to confront the inherent uncertainty that is part of medicine and science, which is a good thing, because then medicine and science can be fluid and changing and, and provide new knowledge, new ways of looking at things. So I think what this work does is it bridges my interest in philosophy of medicine, which is the nature of medicine and science, more medicine, clinical medicine for me, and my 30 years working on death and dying. One other very quick response to it is that, we all experienced great change this year. We've all experienced great loss this year. I remember when we got the memo, okay, time to pack up and go home. The thing I worried about is don't leave the dirty teacup in the office, get the banana out so I don't come back and that kind of thing. And while I've been working on the notion of clinical uncertainty and clinical decision-making since 2012, I began to realize how relevant some of this work is for COVID-19, as my friends and family and loved ones and neighbors all struggled with the questions about transmission, diagnosis, prognosis, treatment, now vaccines. And I began to find, if you will, the relevancy of some of this stuff that I've been doing in my work. So that's what brought me to it. I mean, there's 30 years that brought me to this, but there's also 1 year post March 16 that brought me to this point. So thank you.
Thank you, Dr. Cutter. Let's see, a question for Dr. Barboza as well. How can these data-driven methodologies be useful for informing public policy decisions during this pandemic, as well as, I guess, any future pandemic?
Yeah, that's a great question. I think that one of the points here is that we need regional surveillance, and we need to create a situation where we're using real-time data, and we're disaggregating it to get at the underlying harm to communities and to provide them with the necessary resources they need to combat aspects of the pandemic, in this case, violence. I will say that, the resources heaviest hit I take a public health perspective and not necessarily a criminal justice perspective to this issue. So the last thing that these communities probably need is more police. They don't need more policing, they need more resources. They need access to healthier food, right? If you think about it, 70% of the child welfare cases result in neglect. Neglect and poverty are a tautology. Why are we doing this? Why are we using non-mandated reporters to identify child maltreatment, for example? We need to come up with better methods, and this underscores the importance of data accessibility. We need real-time data. If I use child welfare data for this project, I'd be using data that's 4 and 5 years old. Police data is the only thing that allows me to look at this issue in real time. There are problems with that data. And so really, we need to be more transparent as a society, and we cannot return to a pre-COVID environment. We need to think post-COVID and how to eliminate the gaps in disparities across populations, because violence is not equally distributed across communities. It is concentrated into some of these areas.
Good, thank you. some of the audience has noticed that there are connections within some of the work. And in particular, it seemed like there may be connections between Dr. Cutter's work and Dr. Samuelson's work. So a question for both of you, how might Dr. Cutter's and Dr. Samuelson's work intersect? Do the images, the thoughts of death, especially not being with dying family, impact mental health?
Boy, what a great question. And I thought the same thing as I was watching Dr. Cutter's presentation. And this is what we're trying to get at with our longitudinal research and adding a qualitative component. When people are thinking about COVID, particularly when we think about PTSD symptoms, which are really about intrusive thoughts, being easily triggered, nightmares, what might those look like? And when Dr. Cutter was presenting those images, sure, we definitely think about the possibility of death, but how much has society seen or heard about that idea of dying alone? And how much are they ruminating about that specificity of death and the uncertainty of that? So it definitely, Dr. Cutter, made me want to to add questions to my longitudinal research to try to get at that exact component.
Yeah. Thank you. That wonderful question. I think that our work represents different ways of getting to some really important topics. While I certainly talk about mental health issues and the trauma, that kind of stuff, I'm interested in how the very fabric, if you will, of how medicine is constructed and how institutions are constructed and healthcare facilities are constructed lead us to, if you will, forced choices. And then sometimes forced trauma or forced stress about options and things like that. So I'm not in the psychology department but I think what it shows is that that we can be interested in some similar type of phenomena such as uncertainty and dread. I love that term you use, Dr. Samuelson, and we come at it in some different ways. And I think that's the mark of a wonderful academic community. So thank you.
Good. Well, thank you both. And thank you to all four of you. We are at the end of our presentations today, and I certainly appreciate all that I've had the opportunity to learn during this past little over an hour. So with this, I'm going to turn it back over to Dr. Smith.
Well, thank you, everybody. I really want to thank all of you, our presenters, for sharing your scholarship. And of course, thank you to Provost Christensen for moderating, and thanks to the technology, marketing, and Office of Research team members who helped us organize today's event. And of course, I want to thank all of you out in our virtual community for joining us today. I do want to remind everyone the event has been recorded, so if you tuned in late or want to go back and scrutinize some of those slides or just share with friends and family, you will be able to view after today should you want to return to something or share with more interested people. Because sharing and disseminating research really is a critical part of the knowledge production process. And so that is particularly why I thank you so much. We are thrilled you spent some time with us here today. Take care, everyone.